I'll just start with the slides. So these EDOF, ERV, advanced monofocals or pseudo EDOFs, all are being interchangeably used. Main thing is purpose of all these lenses is to give better intermediate vision. So it creates a single elongated focal line and enhances the depth of focus. Or the depth of focus is in the eye, whereas the depth of field is for the patient. Main purpose is to reduce the phenomenon, all those photopic phenomenon, glare, halos with multifocal IOLs. Initially, when we started using multifocals, we used to have like face lot of chair time wastage. We used to spend so much time with the patients. Once we started using EDOFs, all that has come down. We are very happy with EDOFs as compared to multifocals nowadays. So this is like it should not be inferior to the monofocal group for distance vision. So all these are like. So this is the range of the vision which we get with monofocal. One thing we have to always counsel the patient is that they won't have very good near vision. They will need reading glasses. Once you say they will need reading glasses, you are left alone, or else they will keep bothering you. Always tell them that they will need glasses for any EDOFs. Oh, sorry. This has to be enlarged. So. So these are some EDOFs which we are injecting under saline only. So the limitations is one thing, these EDOFs don't have toric options as of now. So we do correction with like OCC as I mentioned. And there is a learning curve for all newer EDOFs. So either the loading or else implantation. This video, the lower left side, you have a pointer here. So once they inject, yeah, it's okay. So you can see that it got stuck. So they had to like push it or pull it out with force. Luckily, there was no breakage, but sometimes that also might happen. Again, choosing the right IOL and power, all these things we already discussed. So this is one more video. So here the first one, the upper top right left is we are injecting using visco because that was a preloaded lens. For preloaded lens, you need to use both hands. So we the same video, it is a repeat. So there is a difficulty in dialing into the bag. Depending on the different lens manufacturers, you have different marks also for toric lenses, also for the EDOF torics. But main thing is EDOF torics, the tolerability is much better than normal monofocal torics. So even if there is a little bit this way or that way, rotation or no need to redial sometimes. So all these things we already mentioned. Thank you very much. Actually, like this, they got interchanged, I think, some videos. Thank you.
Okay, you said EDOF torics are not available.
Some companies, some manufacturers.
Yeah, some. But you have a lot of EDOFs.
Yeah, a lot of EDOFs with toric options are there.
So basically, what we need to know is if you compare it with trifocals, then today's day, in those patients who regularly do night driving or those patients where you would have avoided using trifocals, you can use EDOFs.
Yeah, we have done mix and match. Suppose there were some patients initially who went multifocals and trifocals who are not happy, either due to they have been having diabetic retinopathy changes as of now. So the other eye we went for a EDOF lenses instead of a trifocal lens.
Diabetic retinopathy with macular involvement?
No, early changes. No, we advise, we always counsel the patient that they might be needing glasses. They will need to wear glasses for reading.
Any correction you make in your IOL power?
A mix and match we do sometimes, but still we advise, counsel the patients like that. So we always, even if you have a stamp, you will need glasses after surgery. So just to not to like, so that we don't, even if you have some, like there initially when the eye hands came, it was like marketed as a intermediate vision. Patients used to ask us, I can't even see my mobiles.
So
Do
if
you-
you're not dominant, you create an offset.
Yes.
Normally by 0.75 diopters minus.
Yes, bilaterally they will be seeing better. That we do that,
So
but
you
still
choose
there will always be some
emmetropic power.
surprises.
You choose emmetropic power in all your patients?
No, usually we go for a little bit myopic in the first eye. The second eye will correct accordingly.
I have a doubt. So, EDOF lenses, they are based on the spherical aberration. So, in case if you leave them more myopic, you are inducing more low order aberration. So, the overall quality of visual experience will be low. So, from what I have read, at least, EDOF lenses work much better if they are closer to zero. Or
Yes.
little more right.
That's the reason you don't give an offset of more than 1. So with what he was talking, non-ring EDOF, ideally you have to give an offset of 1.25. 1.25 or 1.5 actually. Because the non-ring EDOF, what he was talking about, I have one of those things. You need 1.5 offset, but we don't do that. We do a 0.75 and wonderfully works.
We usually go for only point. One more thing is, as I was mentioning, all EDOFs, they have intermediate, sometimes in the intermediate range in the central zone. So suppose it's a pinpoint pupil, we have to always see that it's hyperopic rather than going for myopia.